Audio recording for this meeting has begun.
Well, we'd like to welcome everybody to the SAGES broadcast on hernia mesh primer. This is a topic that has a lot of interest based on the confusion with multiple products being introduced over the last decade that have unique indications and matching the products to the indications. The controversies due to the lack of quality outcomes data to support the use of some of these new novel products. And really the increasing demand on the surgeon, whether you're a practicing surgeon or a resident surgeon, to have an increased knowledge base about some of these novel technologies, how they relate to open and laparoscopic advanced techniques, and really the complexity of taking care of today's hernia patient. Certainly would like to thank Stephen Lamb, the Educational Program Director at University Hospitals Case Medical Center and Case Western Reserve University, for coordinating this event. It's not without the support of SAGES that allows this to occur in the vision of the Board of Governors to fund these projects. As you can see at the bottom of your screen, this is the first of 4 broadcasts this year, with the next one November 15th on surgery in the obese patient, bariatric surgery tips, tricks, and I think it would also be a benefit to the resident surgeon. Just as an introduction, this show is being broadcast using a voice over IP, so you can hear the audio through your computer speakers. If you use the chat pod located in the left hand of the screen, you can type your questions to the panel, and the 2 other panelists who are not actively giving a talk can answer your questions in real time. If you lose your audio or video, exit the webinar, close out your browser, and relaunch your browser and log back into the show. If the problem continues, you'll have to restart your computer. At the end of the show, we hope to have some time for further discussion amongst the faculty and panelists, really as from the questions from the audience. There is a survey that for this, and there will be a web link to get you onto this SAGES survey. We certainly encourage you to take the survey in order to get to know and make our upcoming events even better. These events will continue based on the interest and the feedback we get from the residents and audience. This show is being recorded and will be available online at www.sages.tv within the next 2 to 3 weeks. We certainly encourage you to visit the SAGES website to look at not only this broadcast but previous broadcasts as part of your educational material. So with that, we'll go ahead and get started. The other panelists today are Dr. Yuri Novitsky and Dr. Michael Rosen, both Associate Professors of Surgery and Co-Directors of the Hernia Program at Case Western Reserve University Hospital Center. We will give 4 25-minute lectures. I will give the first on hernia mesh primer, differentiating the characteristics of synthetic mesh, absorbable mesh, and biologics. Dr. Novitsky will give a talk on inguinal hernia, mesh selection for laparoscopic and open hernia repair, navigating the assortment of mesh products. I will then give another talk on hernia repair, technique and location of mesh placement alters biomaterial selection. And then Dr. Rosen will wrap things up with the lecture on the clean contaminated hernia repair, mesh selection when surgical site occurrence is increased. And again, at the end, we hope we have some additional time to answer questions and some faculty discussion. So I will go ahead and get started. This lecture is entitled Hernia Mesh Primer, Differentiating the Characteristics of Synthetic Mesh, Absorbable Mesh, and Biologics. These are my disclosures over the 12 years of being a attending faculty surgeon in an academic medical center. These are the companies or industry sponsors I've worked with the majority of these being for preclinical research. In terms of a primer for hernia repairs, if you're talking about synthetic mesh, the basics of synthetic mesh in terms of differentiating one product from another are really based on this first slide. There are really 4 things to consider in terms of mesh. One is, what is the synthetic material it's made of? Is it polypropylene, which is the most common type of synthetic material for mesh products in the United States? Is it polyester? Polyester, a multifilament polymer in terms of mesh products that is much more popular in Europe. Or is it polytetrafluoroethylene, a much less commonly used material for mesh hernia repairs? The synthetic material itself may have an effect on the material strength, both short and long term, or the chemistry may have a different inflammatory response based on the source material itself. This is broken down obviously into acute response and a chronic response. Probably more important than the material itself is the characteristics of the mesh, and that is the pore size and fiber size. Pore size, self-explanatory. What is the gap or distance that makes up the interstices of the mesh? And this is easy to differentiate sometimes by just looking at different products side by side. And what is the fiber size? So the actual polymer fiber itself can be altered and change the density of the material. This term density is probably a more appropriate way to describe mesh than the component of weight, where you certainly in the published literature terms such as heavyweight and lightweight mesh are used, and we will use that in these talks today, but certainly a better description of mesh such as density is appropriate. This change in pore size and fiber size can have an alteration in the acute and chronic material strength, its compliance, so how flexible is the mesh in relationship to the abdominal wall, the inflammatory action, again this acute and chronic phase of inflammation, and then ultimately the ingrowth or fixation of the material in terms of ingrowth within the mesh and stabilization of the mesh for the hernia repair. More recently, another characteristic of synthetic mesh has been barrier coatings. So absorbable or non-absorbable barrier coatings that are placed on mesh to aid in either adhesion prevention, although it's not truly adhesion prevention, it's more to minimize the tenacity of adhesions, and certainly the effectiveness of these materials is something that is still being studied. So to get to this concept of fiber size, it's fairly self-explanatory through these cartoons that I'm going to show. As you change if you have the same source material, so say polypropylene, and you change the fiber size, as the fiber size gets bigger, the amount of inflammatory reaction to that fiber increases. So it's based on the surface area of the material and density of the material. So the degree of inflammation, although it could be based on the chemistry of the material, it's really based on the mass of the material. So as the total surface area in contact with tissue increases, the total amount of inflammation is greater, as depicted both in this cartoon. Now, how that relates to pore size, in that if you have fibers that are closely aligned with each other, so the interstices or pore size is small, the zones of inflammation begin to merge. And as you can see from the picture to the left, as these zones of inflammation start to merge, there's less room for organized growth within the interstices of the mesh, and that's really what gives the stability of the mesh in terms of its ingrowth into the abdominal wall. If you get those zones to overlap completely, you may get more encapsulation of the material or this scarf plate formation. As you decrease the fiber size and increase the pore size or increase the distance away from each fiber, you can see that the gaps in between the fibers open up, and that allows for more organized tissue ingrowth into the mesh. So this is a concept of small fiber, large pore materials. Now obviously you can take a material that has very small pores but has very small fibers. It could still be a lightweight mesh, but the pore size is different than a like mesh that has small fibers and small pores. And so when you're using mesh materials for hernia repair, this is something that you can use to differentiate the type of material you're using. And again, we use these terms heavyweight mesh or lightweight mesh to describe the increasing density of material as the fibers get bigger and the pore sizes get smaller. So this is an example of a heavyweight or lightweight polypropylene mesh. The mesh on the left has small pores, has a large surface area that's covered with polypropylene or the synthetic material within the surface area of the total mesh. Whereas on the right side, this lightweight material has large pores. It actually has an absorbable polymer within the fibers, but you can certainly differentiate these two when they're taken under the same magnification. Now, in terms of what effect that has, this has certainly been shown in preclinical models and clinical models that as you decrease the amount of foreign material, you decrease the amount of inflammatory reaction, whether it's an acute inflammatory phase or chronic inflammatory phase. And these two graphs depict that, what occurs with the lightweight mesh being the lower area with a decreased percentage of macrophage and inflammatory cells within the wound compared to the heavyweight mesh. Now again, if you start overlapping these fibers, you can actually get foreign body granuloma formation. So in that top part with the circles and the zones of inflammation coalescing with each other, you get a scar plate to form over the mesh, and essentially an encapsulation occurs. And again, this is the concept of large pore mesh, that you can get fibrous ingrowth between the interstices of the mesh and increase the stability of the mesh in terms of the tensile strength. This is a slide that Dr. Novitsky allowed me to use, that he has from some research he did, that shows the difference between these heavyweight meshes at the top, the medium weight meshes in the middle, and the lightweight meshes at the bottom. And you can see this scar plate formation in the upper picture with the white lines essentially encapsulating the material and not getting any good fibrous ingrowth in between the interstices or fibers. Whereas the bottom one, you have that larger gap between the fibers themselves, and that's the interstices of the mesh. Now, what does that mean in terms of strength of the material? As you decrease the density of the material strength will actually decrease. Well, most meshes have been over-engineered in terms of their strength. As you can see from the top of the slide, the mean burst pressure of a heavyweight polypropylene mesh, this is a classic mesh that's been available for over 4 decades, has a mean burst load of 1,218 newtons. If you tried to burst the wall of a porcine model, using a porcine model, the burst strength of their abdominal wall fascia is over 200 newtons. So you can see that the mesh is really over-engineered in terms of its strength compared to the abdominal wall. This lower graph shows what occurs with these materials after they've been implanted. So you have a heavyweight mesh and a lightweight mesh, and you can see pre-implant and post-implant that the lightweight mesh has a burst strength that's almost 300 newtons less than the heavyweight material. Well, after implantation for 5 months, you can see that the lightweight mesh has a burst strength that's still twice the burst strength of a porcine abdominal wall, but its stiffness is quite different than heavyweight mesh, and that stiffness, a better way to communicate that is compliance of the material. So there's much more stretching that occurs around the area where the mesh is integrated. And whether that's physiologic is really to be determined as it relates to abdominal wall hernia repair. Now, how does chemistry play a role in this? Well, not all materials, whether it's polypropylene, polyester, or polytetrafluoroethylene, have the same inflammatory reaction if the fiber is the same size and the pores are the same size. So chemistry may be a differentiator in terms of the foreign-body reaction to that material. Some studies by Dr. Novitsky's group have shown some biocompatibility advantages, potentially of polypropylene versus polyester in the article that I had shown previously. But this is an area that's not well understood, because is the polypropylene from one mesh equivalent to the purity of the polypropylene from another mesh, even if the pore and fiber size were the same, and we really don't know the answer to that. So, in summary, to decrease the amount of inflammatory reaction to a mesh, perhaps chemistry can alter that, but certainly decreasing the fiber size and increasing the pore size. And you've seen that clinically in meshes that have been available for open and laparoscopic ventral and inguinal hernia repair. And Dr. Novitsky and Dr. Rosen will discuss that in their talks. Now, in terms of what occurs in terms of chemistry, I just show this example of a study that we've done previously where we did a retrorectus preperitoneal repair in an animal model. And with that animal model, we implanted 3 different types of mesh: a heavyweight polypropylene, a lightweight polypropylene, and a lightweight PTFE mesh. And certainly at implantation at 3 months, you can see the differences that occur in terms of the wrinkling and buckling around the material that occurs between the heavyweight material and the 2 lightweight materials. That contracture that is occurring is due to that scar plate formation that occurs or encapsulates the mesh. And that encapsulation effect causes the contraction around the mesh and causes the mesh to wrinkle or buckle. This concept of mesh shrinkage is not really the mass of the mesh actually shrinking on itself, but it's this wrinkling and buckling effect from the scar contraction that occurs around the material. So ideally, you would want something that is more biocompatible or almost inert in terms of causing this contracture response. And that's really where the mesh technology is going or developing, and that what can be done to decrease this abnormal inflammatory response in terms of healing with a foreign body. This has also been shown clinically, so this is not just something that's seen in the research lab, and this is a study that's over 11 years old now by Dr. Schumpelig's group out of Aachen, Germany. Their group was really on the forefront of understanding this biocompatibility difference between different materials, again, based on pore size, fiber size, or density of the material. In 121 explanted materials that were explanted at the time of a reoperation, with a mean implant time of almost 2 years, they showed that as the weight of the mesh decreased, or the density, the grams per meter squared, the inflammatory reaction decreased. So this was really the first clinical trial that showed us a biocompatibility advantage for lightweight mesh. Now, there are a lot of different lightweight materials available now, or iterations of medium weight materials from the traditional heavyweight polypropylene that was available for 4 decades. I encourage you to read this article. This is actually an article that was done by Dr. Corey Deacon, who's a biomechanical engineer at our institution, that evaluated these materials to get physiomechanical properties of different types of materials that have different fiber size, pore size, and densities that are used for inguinal hernia repair. Now, the one disadvantage of this study is it only tells you physicochemical properties, how these relate to after implantation in terms of quality of life, functionality, pain, is yet to be determined, but Dr. Novitsky will highlight some of the published literature to date in this area. This is another, again, busy slide that goes through looking at these things to really define what these materials are in terms of their pore size, filament size, thickness, density, and then some just mechanical properties of suture retention, perpendicular suture retention. If you get a partial tear in the mesh, how will that mesh continue to tear? And again, I encourage you to read this as a review. I think the study like this allows clinical trials comparing different materials to understand why these materials may actually act different. As an example of how altering the pore and fiber size can alter mesh performance, I used Ultra Pro, which is a lightweight polypropylene mesh, as an example. This is an article out of Surgery in 2007 that shows that if you put a perpendicular force on the mesh, perpendicular to the lines on the mesh, that the mesh actually elongates 126%. Whereas you pull parallel to the fibers, it only elongates 5%. So as you change the pore size and the weave of the mesh can actually become directionally dependent in terms of how you place it. Obviously, if this is placed in a large ventral hernia repair, not in the direction of forces, where the stretching is in the direction of forces, you could have undue tension on the mesh. So this is what I was talking about earlier about the knowledge base of the hernia surgeon has to increase as these novel technologies are developed for more advanced hernia repair purposes. So if you're using one of these lightweight materials that has a lot of compliance to it and ability to stretch and use it for a hernia such as this is a view from a laparoscopic ventral hernia repair with a 13 centimeter defect, and you get a lot of compliance or stretch within that material, you may get an outcome that is not necessarily desirable. So you have a hernia repair, you bridge that hernia repair, again, laparoscopic or open, that over time you actually get a bulging effect like the lower part of this slide shows. So the patient may come back to the office and not have a recurrent hernia, but they certainly have this bulge at their abdominal wall and aren't real pleased about it. I think as we talk about some of the advanced techniques for ventral hernia repair throughout this broadcast, and getting primary tissue approximation and using these materials really to buttress repairs, it will solve this problem. But if you're doing laparoscopic ventral hernia repair and you're using some of these lightweight materials, this is ultimately the outcome that may occur. So again, matching the appropriate mesh for the appropriate indication will improve patient outcomes or satisfaction. In terms of barrier coatings for mesh, this is what we don't want to occur with the mesh. You're actually getting ingrowth of the intestine into the mesh, and anyone that does reoperative surgery after hernia repair has certainly seen this. So barrier technologies were developed to help prevent this from happening. There are two studies, one in the World Journal of Surgery in 2007 that showed that unprotected polypropylene when placed intra-abdominal has a 21% occurrence of small bowel resection. This is a VA study that showed a similar occurrence of requiring resection of unplanned enterotomy or unplanned bowel resection occurring during elective hernia repair, almost 20%. So certainly we've all seen this in our own clinical practices, and mesh technology needed to be developed to allow us to forego this problem. There are barrier-coated meshes that have been available for quite some time. These are permanent barrier-coated materials that have PTFE as their barrier coating, so a microporous material that doesn't allow ingrowth into the material. There's dual mesh that is all PTFE, and then the barred composites, which has polypropylene and PTFE, with the PTFE being the barrier side. 5 new meshes have been developed over the last decade that have absorbable barrier coatings on it. These barrier coatings work for a certain period of time, and as the barrier absorbs, you get reperitonealization over the material, and that works as a layer, a physical layer to prevent ingrowth into the material, and that 20% rate of enterotomy or unplanned bowel resection is seen in several clinical trials. These materials have the barriers absorb at a different rate, but usually within a 30-day time period, except for the omega-3 fatty acid of Secure. They're made of different types of materials, so not only do you have to think about the barrier, but some are polypropylene, some are polyester, and the fiber size and pore size are different. So now you have another variable in this that not only do you have to worry about the pore size and fiber size in terms of the ingrowth side, the compliance of the material and flexibility, but the barrier itself. The world's literature on this it can be summarized in just a few slides. There's not a lot of, there's really a lack of quality outcomes data in this area. This is an example of PTFE that you reoperate, and it forms this membrane or peritoneum over the mesh, allowing for safe reoperative surgery. In this trial by Richard Kohler, showing that no untoward operative occurrences with reoperation after dual mesh placement, which is PTFE. This is a study out in Hernia Journal in 2005 that showed a similar efficacy for Polytetrafluoroethylene mesh, which is a polyester mesh with a hydrogel coating on it, and that in 6 of 7 reoperations no adhesions were found. There was also an earlier study that's showing by ultrasound that it was adhesion-free in 86% of cases. We did a pilot study several years ago looking at this, as we have a referral practice in reoperative hernia surgery, and trying to get to answer this question of efficacy of these barriers. But you can see of the absorbable barrier meshes, there was 18 that we reoperated on, composites being polypropylene and polyester, the most common barrier-coated mesh used, and then dual mesh, all PTFE. In our catchment area, there were still 12 patients who had uncoated macroporous mesh placed. We looked at outcomes measures such as adhesion tenacity and percentage, how much time it took us to take down the adhesions over that surface area of the mesh, and got this surrogate of complexity of this ratio of adhesion time to mesh surface area. This is the adhesion tenacity score. It's really dependent on the action the surgeon does to take down the adhesions, with 4 being adhesions are so dense you have to cut the mesh off the abdominal wall and leave it attached to the bowel, similar to that first slide that I showed in this area. Again, just as a word of caution, none of these barrier-coated meshes, whether absorbable or non-absorbable, are adhesion preventative. You can see still 2/3 of patients had adhesions of small intestine and colon to the mesh. So although they do have adhesions to the material, you want them to be adhesions that are friendly in terms of the reoperative surgical environment. This slide really summarizes the study in showing that if you use adhesiolysis time to mesh surface area as a surrogate of the complexity of adhesions, we start to see some disparities between materials in terms of the PTFE, barrier-coated mesh, dual mesh, the Secure mesh, the Sepra mesh, starting to separate themselves from the uncoated macroporous mesh, and even the composites mesh that had polypropylene on the ingrowth side. We now are conducting a multi-center trial looking at this to try to answer the question in a more powered, appropriate study, and using this as a pilot. I think this is really what surgeons need to know and want to know in terms of which mesh is best for their patient. In terms of hesiolysis-related complications, in uncoated polypropylene mesh, it was 16%, not too different from the other studies, one cystotomy and one enterotomy. But none of the other meshes we had those problems. Conversion to open procedure, we like to say, is good surgical judgment, but in a larger study we may find that adhesions were difficult in certain barrier-coated meshes, and conversion was more common for that specific reason. As I stated before, you start putting a barrier on the mesh, that barrier is coated to something, and now you have to know more. The meshes may be different in terms of their fiber and pore size and their compliance or flexibility. This is another article by Dr. Deacon that really summarizes the physiomechanical properties of absorbable and non-absorbable barrier meshes for ventral hernia repair. And certainly I encourage you to look at this in terms of getting some fundamental understanding of the differences between these materials. Now, in terms of biologics or absorbable meshes, these are typically used in certain clinical situations, and Dr. Rosen will talk about that in his lecture on the clean contaminated hernia repair. But just to give you an overview of the biologics and absorbable synthetic meshes and why they were developed, I'll go through a few slides here. There are several biologic meshes that are available. So these are biologics, or these are tissues that are taken from either a human or an animal. So the tissue sources are quite different, maybe an allograft or a xenograft. The tissues that are used come from different tissue types: dermis, pericardium, intestinal submucosa. So they're even different in terms of not only the source material, but where they were actually harvested. The processing of these materials to make them antigen-free or decellularized are quite different. Some are irradiated, some are put in detergents, and that may have an effect on the integrity of the matrix that's left behind. Some of these materials are cross-linked. Cross-linking is, in theory, to give stabilization to the mesh, to allow for slower integration or repopulation of cells within the material, to give it a mechanical advantage during that time period of remodeling. There are also absorbable synthetic meshes that essentially work very similar from the standpoint that it's a matrix that allows for cellular ingrowth and then deposition of collagen within the matrix as the matrix is being degraded or reabsorbed or remodeled, whatever how you like to describe it. Potential advantages to this is that there's not the size limitations to biologics, and the economics of this is more appropriate. So just to show you how these extracellular matrix materials work, you have a bioabsorbable scaffold, whether it's a biologic or it's a synthetic material. You implant that material, cells migrate into the scaffold as they fibroblasts integrate into the scaffold. They start to lay down collagen. Other mediators signal the recruitment of other cells within the matrix to get neovascularization and so forth. And that over time the material absorbs and the cells fill the space with new tissue. Now, in theory, you would have 100% of your implant at time 0, and as that implant goes away, you would get increasing collagen in that. A one-to-one replacement would be ideal, and I'm not sure we'll ever get to that point. But understanding what really replaces this material is not something anyone's ever provided previously. We've done a study where we actually analyze and characterize in vivo tissues when they're explanted, and we have an interest in biologic mesh implants. And explant at the time of reoperative surgery. In studies looking at type 1, type 3 collagen ratios in normal humans in fascia, that ratio is approximately 69 to 1. And so ideally it would be close to 69 to 1 at the site of the biologic mesh remodeling. We do have a series of patients now where we've expanded these materials, and you can see here on the slide to the right where we measure type 1, type 3 collagen ratios through red-green staining. And as you can see, the largest ratio we've seen of all the biologic materials is 6:1. So certainly it's approximately 1/10 the type 1, type 3 collagen ratio of normal fascia. So we're not at that level, I think, with these materials yet, where the remodeling is actually fascial-like. And certainly clinically we've seen that. This is, again, pre-op holding in our research lab and doing these repairs with biologic materials to get a better understanding of what the remodeling process is. And although you can have 5 different materials that are very different coming out of the package, and that being time 0 to the left, whether it's Veritas, which is a bovine pericardium, alloderm, which is a human dermis, Permacol, which is a porcine dermis that is cross-linked as a stabilizer, Paragard, which is a bovine pericardium that is a cross-link, or Stratus, which is a porcine dermis that's non-cross-link. They can be very different coming out of the package in terms of their material strength, but over time they become very similar. And if you look at so clinically, we would expect not to see a big difference between materials, but again, we don't know that because the clinical trials have not been done. If you look at composite scores of remodeling, what you can see is the Paragard and the Permacol, which are the cross-linked materials, take a little bit longer as a composite score to remodel, whereas the other ones tend to remodel quicker, and that's exactly what we would expect with cross-link versus uncross-link. There is a potential liability to these materials in if they get into an environment of infection. They can lose their material strength quickly as the proteases or collagenases are released in the wound infection environment and cause a breakdown of these materials. And we've certainly seen this with biologics as well as absorbable synthetic materials. There is one prospective longitudinal trial looking at biologics, and I'll let Mike talk about this later in his talk in terms of outcomes with this. But just to highlight the study is that I don't think we've reached the point now where we have the material that is ideal for these practices. One other thing to consider if you're going to be using any biologic materials, and that is that these come from an animal source or a human source. There may be some cultural groups or religious groups that would not want these materials implanted in them. So informed consent becomes a really important issue in the event that you may use a biologic material. Well, that concludes my portion on hernia mesh primer. And again, I encourage you to ask questions through the chat room, and we'd be happy to answer those as we are going along. The next speaker will be Yuri Novitsky. Yuri's Associate Professor of Surgery at University Hospitals Case Medical Center, Case Western Reserve University. Yuri is co-director of the Hernia Center there. He's going to talk on mesh selection for open and laparoscopic inguinal hernia repair, navigating the endless inventory.
Thank you, Brent. Good evening, everybody. Here are my disclosure slides. I'm going to start with just familiarizing you guys with some prosthetic categories that exist, and Brent has mentioned a few of them. I think just to look at the types of materials used, they're generally, you can break them down in 2 main ones: laminar, and the only example of that would be EPTFE, or known as dual mesh, and other meshes that are woven or knitted. And the 2 major players in that group are polyester and polypropylene, and I'll get back to those properties in the subsequent slides. The materials could be monofilament or multifilament that may play a role as well. And finally, there's some recent modifications that include the reduction of weight and increased porosity, again, as Brent mentioned. And there's some other variations like configurations making them anatomically more pliable and adequate for a particular location. So when we think about mesh choice, what are the factors that we're considering? And I think biocompatibility plays a huge role. We're putting a graft that clearly does not belong in the human body, and we're trying to sort of fool the body to accept it and sort of integrate it and revascularize to the point that it really functions similar to the native fascia. And I think biocompatibility, therefore, is a very key concept The materials that are not biocompatible will induce a higher amount of fibrosis, a denser scar, induce a higher foreign body reaction, and such, with obviously deleterious sequelae to that. I think resistance to infection is a very important concept for mesh choices. Handling and ease of handling, both open and laparoscopically, is important. When we think about those principles for inguinal hernia repair, I think that has significant implications. Mesh choices do matter, and in terms of causing or minimizing growing pain, sensation of mesh, infections, effects on testicular, on testicles and subsequent fertility, and obviously at the end of the day they're there to provide a durable repair and reduce the recurrence rate. So does material type matter? Polypropylene has been around longest, a long time, and in 1940s and 1950s, Dr. Usher presented his first work utilizing polypropylene. It's monofilament. It's been known to provide a very good tissue ingrowth. As a result, we have pretty rapid fixation when it's positioned in the body. If it's not protected, and comes into contact with the viscera, you have pretty significant intraperitoneal adhesions that may cause bowel obstructions, fistulization, and erosions. Therefore, if there's any potential for visceral exposure, polypropylene meshes should be used with protective anti-adhesive barriers. Interestingly, if infected, the integrated polypropylene mesh does not always have to be explanted. The infections could be, the infected polypropylene mesh could be salvaged by some local therapy, and especially more modern, lighter weight meshes are even more amenable to salvage, even in the setting of infection. Polyester is another major material that is used in modern meshes. It's been introduced in the 1950s. The difference with polyester is that it is multifilament. It's kind of braided, as you can see in this slide. It's also results in a macropore structure. Interestingly, polyester is more hydrophilic than polypropylene, which is hydrophobic, and there's some implications on reduction in seroma formation and other potential for fibroblast growth and preloading with fibroblasts on the mesh. And this hydrophilic property of polyester has to be remembered. In terms of handling, polyester mesh is much more pliable than polypropylene. It conforms to the abdominal wall easy, and results in pretty easy positioning. And again, that is a very important attribute of polyester. It does have some problems. It's been reported to be associated with some fatigue fractures. It does have a somewhat higher rate of infection than polypropylene, and in fact, when exposed to the viscera, results in a higher rate of fistulization than polypropylene. And it's also important to point out the reason the infection rate may be higher is because of this multifilament nature, where you can have a mesh that gets ingrown into the tissue, yet you'll have bacteria that's kind of harbored in between the filaments. And as a result, polyester sometimes is associated with kind of chronic draining sinuses, chronic infection that's really difficult to treat. Those features are not critically important for inguinal hernias, but still need to be remembered when mesh choices are made. And finally, in terms of biocompatibility and tissue reactions, without going into too much histology, you can see that polypropylene is associated with some inflammatory response that's lowered as the mesh amount is decreased. As lighter meshes are used, we see less and less of polymorphonuclear cell infiltration and acute inflammatory response. And in our recent work, we show that both EPTFE and polyester meshes are associated with significant proliferation of so-called foreign body giant cells. You can see those arrows are pointing at those foreign body giant cells. These are coalesced macrophages that are the key markers of foreign body response, and you can see it's pretty significantly high in both groups. And in fact, when inflammation is evaluated with polyester group in our experiments, we saw significant proliferation of polymorphonuclear cells both around the fibers and in between the fibrils of polyester, indicative of reduced biocompatibility. And finally, when we measured the foreign body response, I think it's kind of important to point out that on the right you see three groups that are all polyester-based meshes, ultra-pro, Prolite, and Trilex, and you can see that they all are associated with lower foreign body reaction, lower number of foreign body giant cells, both early and at 3 months after implantation, although it's a little bit proportional to the how lightweight the material is. But both dual mesh and Prolite, the Gore-Tex-based mesh and a polyester-based mesh, have higher numbers of foreign body giant cells, and I already showed you the pictures of that. And I want to summarize a little bit, and it'll partially will touch upon what Dr. Matthews has already mentioned, that biocompatibility has been evaluated, and histological evidence of increased inflammation associated with heavyweight polypropylene meshes, and this increased inflammation leads to a thicker scar plate formation and may have deleterious effects on pain and sensation of mesh. Lightweight meshes, on the other hand, induce less scarring and preserve compliance of adjacent soft tissue. We also found that decreased polypropylene content and larger pore size exhibit reduction in inflammation and fibrosis. And finally, I believe polypropylene may be a little bit more compatible than polyester, but that remains to be proven in other investigations. So we're going to switch gears and talk about the main players. And I'm going to be naming some mesh names just to keep it a little bit more real. And there's going to be, I'm going to try to stick to sort of generic names, but I think knowing the trade names is also important. Here are the pictures of Marlex and Prolene mesh. This is a traditional heavyweight polypropylene mesh. As you can see, they have a very dense weave and really have been shown to be mostly over-engineered for most patients, but not all patients. The lighter weight mesh is one of the lighter weight meshes called Ultra Pro. It's made by Ethicon. You can see it's a very pliable mesh. It conforms to the abdominal wall. And on the right, you see a picture of Ultra Pro being used during the laparoscopic inguinal hernia. And it's once it's positioned in place, it conforms very nicely to the abdominal wall. And it's macroporous, lightweight, and is associated with pretty good integration. Another lightweight polypropylene mesh with large pores is made by Bard. It's called soft mesh. There are pieces that could be used both in open and laparoscopic repairs. Again, associated with macroporous nature and have a lighter weight profile. Atrium has, as a company, have introduced a number of meshes that have as a code omega-3 fatty acids that are designed to sort of reduce inflammation and minimize the local response. And they have the mesh called Secure that could be used for both extraperitoneal and intraperitoneal location. Interestingly, the line of meshes by Atrium are lightweight because of the thinner fibrils, but they're still very microporous. So it's one of the few examples of microporous yet lightweight polypropylene mesh that's available on the market. Prolite is a polyester mesh. I don't know if this picture demonstrates it well, but it's a three-dimensional mesh. It's as you can see, it's not quite lightweight. In fact, its weight per se is very similar to heavyweight polypropylene mesh, measuring about 110 to 120 grams per meter squared. So it's not a lightweight mesh, but it's macropore, it's three-dimensional, and it has good abilities for tissue ingrowth. Finally, there's so-called anatomic meshes. They're made from both light and heavyweight materials. You can see that in this corner we have a 3D Max made by Bard. It's a heavyweight pre-shaped mesh, mostly used in laparoscopic inguinal hernia repairs. There's a similar product that's made of lighter weight material, lighter polypropylene material, and it's called 3D Max Light. Prolite's mesh, anatomical mesh, has the two components. It's a main mesh and a little so-called skirt that's made out of three-dimensional polyester. Again, it's an anatomical mesh that's designed to sort of facilitate placement and conform to the abdominal wall. And I'm not going to go into the pros and cons of that construct. The reason I like pre-shaped meshes is because of the ease of use. Dr. Rosen will tell you it's a beginner's mesh, probably because he's envious how fast I can put it in. But you can see once everything is positioned, the fact that the shape is there really allows you to be able to put the mesh and secure it in place in practically seconds, and as opposed to taking 10 to 15 minutes like he does. So there's another pre-shaped mesh or anatomical mesh called Prolene hernia system. It has been used with increasing popularity. I think it's been used in Europe as well, designed by Dr. Gilbert from Florida, who essentially has a mesh that has two leaves, and one of them goes used in open repair. One of them goes behind the floor of the inguinal canal, and another leaf goes above the inguinal canal. So you kind of have a double layer and for your repair, and there's actually a lighter weight construct, although it seems like you're going to be putting twice as much material, and even though it's a lightweight, it's still going to be pretty quote-unquote heavy overall. And plugs. And plugs have had a very interesting history. You can see this essentially polypropylene meshes that kind of wadded into this cone-shaped products that are being placed in inguinal defects, and sometimes it's the only repair. And there's actually a lighter variety of plugs. Again, there's some limitations for use, I believe, and although the literature doesn't report quite the complication rate associated with that, those of us who are in practice take out a lot of these due to chronic pain, and I think the complications associated with the use of plugs is generally underreported. On the right, you can see a plug produced by W. Gore called the BioA. This is the same material that Dr. Matthews has talked a little bit earlier. It's an absorbable plug that will create hopefully some scarring at the site of inguinal defect and could facilitate the repair. A recent development of a self-ripping mesh, and I want to like to shout out Dr. Jacobs from New York for allowing me to use his slide. It's a polyester-based mesh that has those hooks. They're polylactic acid-based hooks that allow fixation of the mesh. Essentially, put it in there. It's almost like a little sandpaper-ish that allows pretty rapid fixation and could be used in both open and laparoscopic routes. Having said that, laparoscopy could be quite cumbersome, and the learning curve is significant to make it, because once it's there, it's very hard to move it, and you better be right the first time. All right, so I think I may not have presented every single mesh available on the market, but I did want to point out that there are lots of players, lots of products that have properties, and we'll go through them again to see which ones could be, which ones are better or worse for particular indications, and I'll try to cover some pros and cons of those meshes. So, and again, just to summarize, there's heavyweight, in terms of polypropylene, there's heavyweight microporous mesh, and this is Marlex, Prolene, Trilex. Those are heavyweight, older version meshes. There's a lightweight microporous mesh, still microporous, but already lightweight, and mostly it's Prolite and Secure, the meshes made by the Atrium company. There's a lightweight macroporous mesh, which the two prime examples are UltraPro and Soft Mesh by Bard, UltraPro by Ethicon, and this this is the lightweight meshes. And finally, there's a heavyweight macroporous mesh, and this is a polyester-based Prolite mesh. All right, I'm going to switch gears and try to present some of the clinical evidence that's been associated with the use of those meshes, and just to try to see which meshes perform better in certain circumstances. And I want to preface that there's a lot of literature on the meshes in this, but unfortunately there's not as much of a good literature. And I looked through a lot of studies, and a lot of them are single surgeon experience reporting some data and saying the mesh works pretty good. And I don't think it's scientific enough, and those studies were not included in this review and in this talk. A recent study, there's very little literature that will look at polypropylene versus polyester as a material. Very little data exists on the topic, but there's a recent study published in Hernia, a comparison of polypropylene and polyester meshes during open Lichenstein repairs with respect to chronic pain and discomfort. Very important trial. It was prospective randomized trial with 39 patients enrolled in each group. That was underpowered. The original power analysis suggested almost twice as many patients, so clearly a pretty significant problem. They used visual analog scale and authored to design Inguinal pain questionnaire as well as clinical exam, both 2 weeks and 3 months after surgery. What they found was the following. There was no difference in pain based on VAS at either time point. In fact, patients were pain-free at 3 months. 23.6% of patients in the polypropylene group were pain-free, as opposed to almost 18% of patients in the polyester group, which was not statistically significant. But when questioned further, sensations of catching, pulling, or tearing were significantly more common in a polyester group. Notice it's 5.8% versus almost 34%. And the authors concluded that polypropylene may be superior. Another study that looked at the effect of reducing the weight of the mesh in a prospective randomized fashion. This is out of British Journal of Surgery. They looked at almost 600 men undergoing open repair and compared heavy and light meshes. Again, using clinical exam and pain questionnaire with a median follow-up of almost over 3 years. Importantly, they found no difference in testicular atrophy, neuralgia, or any non-hernia related problems. In terms of pain, they found no difference in pain in the groin, pain that would impede daily activities, sports, or exercise. In fact, over 80% of patients in both groups reported normal sensation in the groin. However, significantly more patients in the heavyweight group could still sense the mesh during the follow-up, 23% versus 15%. In fact, 3.3% versus 0.8% of patients experienced pain on palpation of the groin. And there were no differences in recurrence. And the authors concluded that there was some evidence that lightweight mesh may be beneficial in terms of reducing the sensation of mesh and reducing some discomfort in the groin. Another study of mesh being used in inguinal hernia repair, randomized control trial, 122 patients that were undergoing either lightweight or heavyweight repairs. And again, pain scale was administered early on at 6 months post-op. So lightweight mesh patients had less pain on exercise, and significantly more patients had severe pain. But notice, even though I'm saying it's less pain, it's statistically important, but if you look at their numbers on a scale of 1 to 10, both groups were less than 1, and lightweight mesh was clearly significantly less, but still both groups were associated with pretty small amount of pain. And again, there was a significantly less sensation of lightweight mesh, 17% versus almost 44%. So we continue to see this trend that lightweight mesh is leaving kind of, it's not as apparent with time, and probably because of the reduced foreign body response. Now we're switching gears and looking at some literature for the laparoscopic inguinal hernia repair, a prospective randomized trial, UltraPro versus Prolene, almost 200 patients, but again, telephone questionnaire. This was not a physical exam-based study. They found no difference in pain or discomfort. However, they determined that there was significantly less interference with physical activity in the lightweight group in both long and short term, as shown by the numbers here. Prospective double-blind control trial of both types of mesh, again, in laparoscopy. And this, I think, is one of the more interesting results that I have seen and more compelling facts that I found in literature. These guys did 25 bilateral hernias, and the results were assessed by independent examiner pretty frequently. Each patient served as their own control. They implanted a heavyweight mesh on one side, and lightweight mesh on the other side. And every single patient in the group was able to detect which side had the lightweight mesh. 25 for 25 times the patients were right guessing which side was different. And I think it's very compelling if you think about it, that there is something to this difference in mesh weight. And however, there was no significant difference by 3 months and 1 year. When they looked at pain scores, they did find that the pain scores overall would continue to be slightly better in the lightweight group, and as a result, the authors concluded that the outcomes of lightweight mesh were significantly better. And I think there's a degree of improvement. I didn't quite share the enthusiasm of these authors how much better the mesh performed. I think I'm gonna kind of finish up with the clinical investigations, but I also want to point out this recent animal study that looked at the effects of the use of lightweight mesh on the function of, on the testicular function and possible fertility implications. Again, this Dr. Schimperling German group that looked at open repairs in rabbits. They looked at both heavy and light mesh, and 20 animals were used, and each of them was their own control. I don't think they could pick out which one was which. But they used pretty sophisticated methods to determine how the meshes performed. They used vas deferens vasography. They looked at histologic evidence of mesh-host interface, measuring foreign body response. And finally, they looked at spermatogenesis using established scales. What they found that at 6 months, there was no difference in spermatogenesis, significant vas deferens obstruction, and they defined it by more than 75%, occurred in half of the Prolene group and only 22% of the time in the lightweight mesh. And histologically, there was clear-cut evidence of higher foreign body response and giant cells in the heavy group and much lower in the UltraPro group. And they were able to conclude that lightweight materials are beneficial in young patients, especially if we're aiming to preserve the vas deferens integrity. I'd like to summarize what I've said by just kind of highlighting a few bullet points. I think there's a vast histological and immunohistochemical evidence of lightweight macroporous mesh benefits. I think the benefits of the lightweight meshes in inguinal hernia repair include reduction of mild to moderate chronic groin pain. There's decreased lightweight mesh sensation, especially in the long term. There is decreased limitation in activities with lightweight mesh, and there's actually possible preservation of vas deferens integrity. There's a small suspicion that it could be there could be increase in the recurrence rate, but I think that there was an early experience in appropriately used patients. That's probably not a factor. I also think polypropylene may be superior over polyester, although this evidence is inconclusive. and there's also insufficient evidence of anatomical mesh benefits until we have better prospective control trials comparing anatomical and standard mesh products. So after you've heard everything I said, how do we choose the mesh? What mesh should I use? That's the bottom line question. I think you need to consider hernia characteristics. We need to see whether it's a direct or indirect inguinal hernia. I think direct inguinal hernia should really be viewed closer to the ventral hernia, and indirect inguinal hernia is a much different process. It really, because of the shatter mechanism, I think the products that we use to treat those do not have to be as durable and as engineered. The size of the defect matters, and in the groin, and we'll talk a little bit more about it in a panel discussion. Whether you're using open or laparoscopic technique, the mesh considerations matter. And finally, who are we operating on? How old is the patient? How important it is to provide the factors that I described before? How important it is to not limit their ability to exercise and perform other functions. So the level of function, the fitness, is key. Provided the answer. So let me give you just a few scenarios. What mesh should I use? We have a 24-year-old athletic guy undergoing a lap inguinal hernia. A small direct defect is found in surgery. Which mesh choice is least suitable? And I highlighted what I think is least suitable. And lightweight mesh is perfectly appropriate. Polyester mesh, although I've said there are a few drawbacks that exist, still a frequently used mesh, very easy to handle, conforms to the abdominal wall really well, so quite appropriate. Polypropylene mesh with omega-3 fatty acid coverage. Actually, that's not the right answer. I don't know why it came out this way. But this is a lightweight mesh, although it's microporous, it's still a lightweight mesh. And finally, Marlix is an example of heavyweight polypropylene mesh. And again, in a young guy undergoing a repair of a small defect, I think the heavyweight polypropylene mesh is probably least suitable. I apologize for. Another example, 54-year-old male presents with a failed or recurrent inguinal hernia. He's scheduled to previously repaired open. His BMI is 32. Which approach mesh choice is most suitable? Open repair with a lightweight polypropylene mesh. I think in this guy, the lightweight mesh may not be as important given his BMI and his overall state. I think laparoscopic repair with a heavyweight polypropylene mesh should be considered strongly. This is a patient who's had previous open repair is probably more suitable for laparoscopic repair. And again, in this heavy guy, the use of a lightweight mesh, especially if the direct defect is found, is probably not wise, given the fact that it might lead to postoperative bulging, and probably he's unlikely to derive long-term benefits. Other repairs, laparoscopic repair with a lightweight mesh, I think, again, should probably be avoided. And finally, open repair with a polypropylene patch and BioA plug is not advised, just given the fact that he's already had a failed open repair, and laparoscopy should be preferred. Last question. So we have a 68-year-old male presenting with a large inguinal scrotal hernia. He has a history of heart disease and rarely leaves his house. Which approach is less appropriate? Again, I think for this guy, open repair with a lightweight mesh is okay. Self-gripping mesh is fine. Open repair with a Prolene hernia system is okay. Clearly, I think laparoscopy in this guy is contraindicated, and open repair just using a plug is going to be insufficient. So to conclude, do we know what the ideal mesh is, and do we have, quote-unquote, the winner? I don't think so. In fact, synthetic meshes may never be ideal and will continue to evolve. It is important to remember that one size, one mesh does not fit all the problems, and we really need to know mesh properties and need to use them accordingly. And I want you to remember that it's not about ideal mesh, it's what's appropriate, and hopefully with the knowledge you gain today, you'll be able to make smarter choices going forward. Thank you.
Thanks, Yuri. I encourage people to continue through the chat room with this broadcast to ensure that you have your active questions get answered. Dr. Rosen and Dr. Novitsky are available now, certainly, to answer those, and myself after this talk. The next talk is going to be hernia repair technique and location of mesh placement alters biomaterial selection, and I think you will. Some of this we've already covered, and some of this may be a little bit redundant, but it emphasizes several points. And the biggest point being that with multiple products introduced over the last decade that have unique indications, making sure that the biomaterial selection is appropriate for the indication needed to increase the quality of the outcome. I do not have a disclosure slide with this. I can promise in the last 45 minutes my disclosures haven't changed. Not all hernias are the same, and so when I have a patient who comes in with a hernia, the first question I really need to answer for that patient is, what technique am I going to use? Am I going to use a laparoscopic technique, or am I going to use an open technique? If I'm going to use a laparoscopic technique, for the most part that's a standard technique of bridging with the mesh, placing the mesh against the peritoneum. Occasionally you can do component separation and release endoscopically and close the defect primarily, or try to close the defect primarily with a suture passer. But again, the standard technique is going to be bridging of that defect. Now, a hernia like this, again, a patient came in the office. This patient would really be appropriate for laparoscopic or open. So you have the conversation with the patient about what are their goals of treatment. Is it functionality? Is it minimizing wound complications? Is it a combination of both? And so that's really the first thing that I think of. And then other hernias, patients will come into your office and they really only have one option, that option being an open technique. Either they have an active wound problem, they have a hernia that's too big to do laparoscopically, they've had multiple abdominal surgeries, peritonitis, they have previous mesh placement intra-abdominal. Whatever the indication is, that's going to push you towards an open technique. And so once you decide on that open technique, you have to decide, is that going to be a technique where I place the mesh intra-abdominal, simulating a laparoscopic ventral hernia repair? Is this a technique where I'm going to put the mesh in the retrorectus space or preperitoneal space, the so-called sublay Reeve Stopa type repair? Is this a hernia repair where I'm going to do a component separation release and then use a combination of the Reeve Stopa for retrorectus repair, or preperitoneal or intraperitoneal? Now, a lot of these decisions don't need to be made in the office when you're evaluating the patient or reviewing their CAT scans from an open technique. I think as a hernia surgeon, you have to be comfortable with all these different techniques, so you can potentially alter your technique based on the anatomy that you see in the operating room. But again, just to highlight with these kind of gross demonstrations that not all hernias are the same. And then there's other hernias that require a completely different approach, such as these clean contaminated or contaminated operations, and Dr. Rosen will go into more detail about this. But a patient who comes in with a mesh infection, you have to explant the mesh, and now they have a abdominal wall defect. Or a patient who comes in with an incarcerated hernia that requires a bowel resection, and then some kind of technique to salvage that situation. Are you going to do a one-stage repair, or are you going to do a two-stage repair? So the biomaterial that's used is going to be quite different potentially for these clinical scenarios. Again, the elective, straightforward ventral hernia repair, laparoscopic versus open, the more complex hernia repair that requires open techniques and potentially advanced techniques, such as component separation that may increase the amount of wound morbidity experienced, and then these more stressed hernia environments of a mesh infection or a clean contaminated or grossly contaminated operation with an incarcerated hernia. Now, as a point of emphasis, laparoscopic ventral hernia repair has never reached a point where it is the majority of all repairs done in the United States. Still, the vast majority of repairs done in the United States are in an open fashion. About 25 to 30% of all ventral hernias are done laparoscopically. Despite the fact that prospective randomized trials have shown a morbidity advantage, meaning a decreased morbidity for a laparoscopic technique. So again, a patient comes to the office, the first thing you need to think about, laparoscopic or open. If my goals of treatment excuse me, and the goals of treatment for the patient are they've had previous wound infections, they've had they don't have a high functionality or a lifestyle that's more sedentary, then I will move towards laparoscopic repair. This is just taken from that article. It's a prospective randomized trial done here in the United States through the VA that's showing that as a primary outcome parameter, overall complications between laparoscopic and open, there's significantly less overall complications. If you look at specific complications such as wound morbidity, there's a significant decrease in wound morbidity related to the laparoscopic repair. And I'm talking about wound morbidity that requires some kind of, or surgical site occurrence that requires some kind of intervention. Seroma rates we see in some studies with laparoscopy are very high, but the actual number of seromas that require intervention is extremely, extremely low. Now the meshes that I'm going to use laparoscopic or open are going to be quite different. So if you're going to, your intentions are to do laparoscopic ventral hernia repair and bridge a defect where the mesh is placed intra-abdominal, such as depicted in these pictures, then you have to use a mesh that, when exposed to the intra-abdominal cavity, has some biocompatibility or safety to it. So those meshes that I talked about earlier with an absorbable or non-absorbable barrier coating are appropriate for intra-abdominal placement. Now, there is a cost to using these materials in terms of increased cost of the material itself versus an uncoated material. So we certainly don't want to be using materials that have an economic disadvantage when they're and they don't need to be used because they're not being exposed to the intra-abdominal cavity. This patient here has a piece of PTFE or dual mesh placed, and you can see with that large surface area that exposed the intra-abdominal cavity, you certainly want it to have a biocompatibility that's appropriate for intra-abdominal placement. So in terms of mesh selection, if I'm going to place mesh intra-abdominal, and for me personally that typically is a laparoscopic approach, these are my selections that I can choose from. The top 5, the Polytex composite, the Prosthetic, the Sepra-Mesh, the C-Cure, and the Physio-Mesh, all have an absorbable barrier on them that absorbs over a period of time. And again, in theory, you get reperitonealization over the mesh, and it inhibits or minimizes the amount of ingrowth into the material. Dual mesh and composites mesh that have the PTFE-based barrier, so this is a permanent barrier, so there's no concerns regarding the barrier's longevity and how the patient's biology may affect the barrier absorption or breakdown. And those are the other 2 options. Now, in an ideal world, we'd know exactly which material works the best, and again, that prospective longitudinal trial that we're coordinating will hopefully help answer some of these questions. But it's also unrealistic for materials management to be able to stock 7 different materials for intra-abdominal placement. So I think, you know, as someone hopefully being responsible, you certainly having available a non-absorbable and absorbable barrier material, I think will certainly help. The disadvantage of using PTFE-based materials in an open fashion is that if PTFE-based materials get infected, they almost always have to be explanted. So for me personally, if I'm doing an open approach and I need a barrier-coated mesh, so I'm doing an open ventral hernia repair, I'm going to place the mesh intra-abdominal, then I use one of the macroporous absorbable barrier-coated materials, so one of the barrier materials from the top 5. If I'm doing a laparoscopic repair, then that's when I would use my PTFE-based materials. Now you certainly, or one of the absorbable barrier materials. For me personally, if I'm doing a peristomal hernia repair laparoscopically, using something called the sugar baker technique where you make a tunnel with the bowel tunnels against the abdominal wall, to me that is an absolute indication to use a PTFE-based material. Now I'll get disagreement from other people from that, but the PTFE side, that is the ingrowth side, should not erode into the intestine. So again, intra-abdominal repair, some people call that a sublayer repair, but it's really intra-abdominal, so the mesh is placed intra-abdominal. These are the mesh selections to choose from. PTFE-based materials, more for laparoscopic approach because of a higher risk of infection with an open approach and requiring explantation of the mesh. and then using the macroporous materials for the open repair. Again, that's how I break this down in my own surgical practice, but it may be very different for other surgeons, and certainly different based on the potential wound morbidity of that patient's situation. I talked about this earlier, but again, you have to remember that if you're going to bridge hernia defects, whether it's open or laparoscopic, for me, I want to use a material that is less compliant or more stiff, so the patients don't get this bulging effect over time as the scar plate softens up and the mesh demonstrates its true compliance. Now, there probably is a defect size that becomes critical in terms of not having this bulging effect, whether that's 2 centimeter width, 4 centimeter width, 6 centimeter, 8, 10, or on. We don't know. I certainly don't know the answer to that, and I can't tell you what's a big hernia that requires potentially a less compliant material. Again, this is just one of the outcome variables that's also that you need to think of, including recurrence, chronic pain, and so forth. But we certainly see in successful hernia repairs where patients don't have pain that come back with bulging from these less dense or lighter weight materials. So doing a large open ventral hernia repair in this fashion with a lightweight material where you're bridging this, you can see the bulging that's already occurring before skin closure, and you can imagine the bulging that's going to occur later would be something that a mesh material I wouldn't choose because of this having to bridge this defect, because this hernia is so grossly big that primary closure is not possible, even with advanced techniques such as component separation or Reeve Stope posterior rectus release or a combination thereof. Now, when I do an open hernia repair and I'm going to place the mesh within the layers of the abdominal wall, whether that's preperitoneal or ideally in this retrorectus position, so the slide shows the closing of the posterior rectus sheath after the rectus abdominis muscle has been dissected free of that posterior rectus sheath. That dissection continues laterally into the semilunaris line. So you develop this pocket in which to put the mesh in. It usually affords a minimum of 4 to 5 centimeters of overlap on either side, and then of course you can get overlap superior and inferiorly down into the pelvis and the spacer rettius or up underneath the diaphragm by dissecting out that preperitoneal or that fat pad posterior to the xiphoid. This is an ideal location for mesh because of the biocompatibility of it being in a well-vascularized tissue. You have muscle above, you have fascia below. Putting a wide pore mesh into this area would maximize the amount of ingrowth into the material. And certainly this is my procedure of choice with open ventral hernia repair, as long as this myofascial release of the posterior rectus sheath allows for posterior and anterior closure. If not, then go on to a component separation release. So the mesh is placed. This is an open suture passer called a revered needle. The suture is placed within this pocket, and whether you place the sutures externally so they tunnel through the skin, so this looks like the laparoscopic ventral hernia repair with an open incision essentially, or you make flaps anterior to the rectus sheath and place the sutures through the rectus sheath, the mesh gets tucked in this space and then the anterior rectus sheath is closed over the top. And so again, this is an ideal location in terms of maximizing the biocompatibility of any material. Now, the other technique, and Dr. Rosen will go into this in more detail, is the component separation technique, where you make a myofascial release laterally to get primary closure. Again, open technique, for me, if I'm doing an open technique, my goal is to get primary tissue closure. There are times where I can't do that, and I have to bridge a defect, but I'd rather have the mesh within the layers of the abdominal wall. In these clinical situations, I'm going to use one of these macroporous meshes. Now, again, we have heavyweight materials, we have lightweight materials, the lightweight materials being more compliant or flexible versus the heavyweight materials. Now, there has been clinical trials actually looking at this, whether heavyweight or lightweight polypropylene mesh has an advantage in a situation of open ventral hernia repair. Well, really the first studies that were done were looking at this Reeve Stope technique were mesh versus no mesh at all. Now, there are a lot of surgeons still performing incisional hernia repairs without mesh, and certainly with 10-year cumulative recurrence rates doubling with not using mesh, and mesh being more important for the smaller hernias, there's really not a clinical scenario in an elective fashion where you don't have where it's a clean operation, that mesh should not be used, even for small hernias. So certainly resist the temptation of closing an incisional hernia primarily without mesh, because certainly the short-term data and more importantly the long-term data shows that mesh really does make a difference. Now, what kind of mesh does make the difference? This particular study was done with heavyweight mesh versus no mesh at all, but still a 32% recurrence rate at 10 years, and there's a lot of room for improvement in that. In this study, the same group that participated in this previous study, some European surgeons looked at using that Reeve stopper repair, that open retrorectus repair, using a heavyweight material versus lightweight material for incisional hernia repair. Now, this study was underpowered, and they did have a mix of polyester and polypropylene, but the interesting part of this study showed that at 24 months mean follow-up, you started seeing some disparities in outcomes in terms of recurrence in the lightweight versus the heavyweight or standard weight mesh, with a higher recurrence rate in the lightweight mesh. So I don't know we know everything that we need to know yet about how to use lightweight materials for open ventral hernia repair. Again, my preference in an open ventral hernia repair is to use a macroporous mesh, place it in that retrorectus or preperitoneal space. I tend to use heavier material for the larger mesh, larger defects, or the defects that I feel are under more tension. And I use the lightweight materials for those smaller hernia repairs, or those hernia repairs that are under a lot less tension. Now, when a surgeon has to make judgment about tension and other things in the operating room, obviously that's very unscientific, and I hope that in the future we know exactly what's the right material for the right indication with these open hernia repairs. But again, if you can place it in the preperitoneal or retrorectus space, a barrier coating is not used, so you don't have to worry about those materials that are used for laparoscopic or open ventral hernia repair with intraperitoneal placement. Now, Mike will go into this, Dr. Rosen will go into this in more detail, but when do you use a biologic or an absorbable synthetic? Well, obviously in the grossly contaminated operations where you have things like mesh infection or mesh exposure and you have to reoperate on those patients, that's when you're going to use it. This is an example of a mesh infection where the mesh is going to have to be explanted. Well, you're going to have to do something to get closure of that abdominal wall. Primary closure of this abdominal wall is likely to lead to a hernia. The most common most common risk factors for recurrent hernias include a previous wound infection, a reoperation within 30 days. So if you have one of these events occur, in all likelihood you're going to have a recurrent hernia. Now, recurrent hernia is acceptable if you're getting somebody out of trouble, and a two-stage approach is appropriate, and certainly talking to patients about this is very important. But certainly there may be some things we can do up front to minimize the two-stage approach. This is another example: intercutaneous fistula, mesh erosions requiring mesh explantation. Small hernia going to require repair, and what kind of materials are we going to use? I showed this earlier. You can certainly use the biologic meshes. You can use the absorbable synthetic meshes that are available, but a mesh that is more biocompatible in a stressed wound environment, so your clean contaminated or contaminated wounds. It's rare that we ever leave the operating room with a grossly contaminated wound, and certainly we don't usually put in any kind of material in a grossly contaminated wound. We bring those patients back to the operating room. We decrease the bioburden of that wound before we would place one of these bioabsorbable materials. I think the real difficult thing that surgeons are struggling with is trying to grade what is a grossly contaminated, clean contaminated, or wound at risk. The Ventral Hernia Working Group, which Dr. Rosen, I think, was a member of, tried to define these grade 2 hernias in this 4-grade system as to who's at increased risk of having wound morbidity, and should we be using these biologic or absorbable meshes in that group, such as patients who are smokers, obese, diabetic, they're immunosuppressed, they have COPD, so all these comorbidities that patients may carry with them. To date, there's not really any good studies that show us what is the right patient for using these reabsorbable materials that don't have an active wound problem, but I know Mike and his other groups are working on these studies. For me, the ideal location to put a biologic graft or absorbable synthetic graft is the same place I would put a graft in an open repair. So if I'm using a biologic graft or absorbable material, I'm going to put it in this retrorectus preperitoneal space if possible. Again, you have muscle above, fascia below. It's an ideal area for biocompatibility. Certainly in the past this was done. This is how we placed biologic mesh over a decade ago, thinking that the biologic mesh would remodel into fascia. We've shown from our explant studies that that doesn't really occur, and you get recurrent hernias. I'm sure Mike will talk about this in terms of bridging versus not bridging. So in a technique where I need bridging and I need to use an absorbable mesh such as a biologic, then I know what that outcome is going to be. It's going to be recurrent hernia. Now that's acceptable to get that patient out of the situation, but that's going to be a two-stage repair. So again, if I'm going to use those, I'm going to try to get reinforcement with the mesh and alter my technique. Again, Mike should talk about this trial, and I certainly won't go into it. The advanced techniques such as component separation allow you for primary closure and to use these absorbable or biologic materials as a matrix for collagen deposition and reinforcement. The era of vicryl mesh with bridging, letting the wound granulate, doing a split thickness skin graft, I think are not gone, but certainly are becoming less frequent. This technique is associated with almost a 10% fistula rate prior to abdominal wall wound closure. It requires a second stage procedure with a very difficult abdominal wall to deal with. So certainly advanced techniques are trying to get away from this, and the new materials that we're using are allowing us to do so that you don't have a four-stage repair, a lot of resource utilization, a lot of potential morbidity to the patient that occurs, and again, this fistula rate that approaches 10%. One last thing in terms of morbidity that I'm not sure anyone's going to cover, and I just want to talk about, and that is the importance of getting people to stop smoking. Smoking is the single number one greatest modifiable risk factor for changing patient outcomes. Smoking has been shown to increase the risk of wound infection, increase the risk of hernia recurrence. We get people to stop smoking preoperatively. We test their urine for metabolites of nicotine to ensure they've stopped smoking. And despite the fact that you do this laparoscopic or open, but more so in the open group, it changes the potential morbidity to the patient. So with that, I'd like to hand this over to Dr. Mike Rosen. Mike's Associate Professor of Surgery at Case Western University Hospital Systems in Cleveland. He's a co-director of the hernia program there. He has a lot of experience in clean contaminated hernia repairs, done multiple clinical trials in this, and so he's going to talk about the clean contaminated hernia repair mesh selection when surgical site occurrence is increased.
Okay, well, thanks, Brent, and real pleasure to be here. And again, you and Yuri, excellent couple talks, and really enjoyed it. So hopefully we can keep the discussion going on. I'll try and say some controversial things during my talk as well, just to spur things on. So, let me go this way here. I do have some disclosures, and obviously we're going to talk about mesh today, as the other speakers have, and I'm going to try and keep this to basically just published data and some of the animal work that we've actually done in our lab. So as you've kind of heard throughout today, I think that one of the most important things to realize about hernias, and this is one of the things that I like most about fixing hernias, is you can have these small 2-centimeter umbilical hernias up to some of these really massive hernias with complete loss of domain. And across that whole spectrum, I think it's important to realize that not only is there never going to be one mesh that takes care of all these problems, and there's clearly going to be a role for synthetic mesh in hernia repair, and I think there's clearly going to be a role for biologic mesh as well. I think the same thing is true for technique, in that there's multiple different techniques that you have to take into account, including laparoscopic repair and some of the more open, really challenging type of things that we do. And one of the things, when you go from this type of hernia into the same type of hernia where you have infected mesh and you have fistulas and you have stomas there, it really ups the ante and makes things a lot more complex, and kind of what are your goals and what are your objectives, and what is the morbidity associated with these operations. And so, maybe the 4 take-home points for me, for my part of this, will be that these, in my opinion, all hernias, but certainly clean contaminated ventral hernias are tough problems, and there is no chance that any mesh is going to offer an easy solution to this problem. But obviously this is an area, as Brent mentioned, that we use a lot of biologics, and I'll try and tackle this question of when should you use a biologic mesh, but I would just tell you that I think it's really important to realize that we don't know the answer to that question, and we need more data to really answer that clearly. And then we'll talk about some of the differences between these meshes, and then I'm going to spend a little time on technique, because I think that really is important. And going on to kind of that theme, this is kind of a picture from my pre-op area. As you can see, the patients come in. They usually have 3 parts to them. They usually bring their baggage, because they tend to stay 30 to 60 days in Cleveland after you operate on them. But I use this to kind of really stress the point in teaching that there are really 3 parts to every hernia operation, and you have to address each one of these, and they're equally important. In patient optimization, I'm not going to really talk about tonight, but I think that's critical. You heard a little bit about smoking cessation. We didn't really talk about obesity, but that's very important. Try and get the weight reduction in some way, optimizing their nutrition, taking care of the skin, and getting them as pre-op optimized as you possibly can. If you fail that, there's no chance in whatever procedure you choose or whatever prosthetic you choose. Obviously, I'm going to focus on prosthetics and a little bit about procedure as well. So when you look at kind of what is a complex or a challenging hernia or an infected or contaminated hernia, again, we all have our own definitions, but if you look at this lady, that's actually her belly button kind of in the middle, and she had a J-tube that fell out, and she lost the whole left side of her abdominal wall, and she was reconstructed with Marlex mesh, a skin graft, and now she's got 2 fistulas. And I put that up because it's important to understand what we're talking about here. And when we look at this patient, if I show you her 4 years later, her CT scan, and she has a 4-centimeter asymptomatic hernia, is that really a failure in this operation? Well, we'll record it as a recurrence, and some of these folks, it's just getting a stable, clean wound and getting them out of the hospital alive. And I think that it's, when we're talking about 3 or 4 centimeter hernias, I think recurrence rate is key, but in some of these more complex situations, I don't think it's that simple. So when you look at, okay, what am I learning about? Where am I getting this information? Well, the truth is there's very little peer-reviewed publications, but there's more and more interest in this, and it's coming. But you all have to realize that there's a lot of money on the table, and there's over $400 million spent on biologic mesh last year in the United States. It's the first year that it's surpassed. Synthetic mesh was $320 million, and next year is projected to go over $500 million. And so I think that when you have that much money on the table, there's a lot of marketing influence in this field, and I think it's important that every one of us realizes that and really looks for what is the appropriate data in the selections that we do here. And so if we look at the data, there's 12 FDA-approved products that could be on your shelf for abdominal wall reconstruction, and to date, 2 of them still do not have 1 peer-reviewed publication. 3 of them only have a small rodent single publication. 3 of them only have 1 human series published with short-term follow-up. And really, only 1/3 of the meshes that are on your shelves actually have both animal and human data that is out there to support them. And so really, a lot of unanswered questions, which is exciting for young scientists, but it should make you proceed with caution as a clinical surgeon. And so I'm going to tell you that I don't know the answer to this question, which is when should we be using a biologic mesh, and I'm going to try and stress why we don't know that. And I think that, number one, realize that we don't have a classification system. And so your complex hernia might not be my complex hernia. And when you add on the fact that we can't even agree on surgical technique, and realize that sometimes the surgical technique that you choose, I think Brent showed some nice pictures of an open component separation. Those are major skin flaps. And if you do that, and even in a clean patient who's slightly overweight, you might increase your wound morbidity up to levels of, in fact, an infected or contaminated hernia. And that should play into what type of mesh are you choosing and what location are you placing it in? Because if you're raising big skin flaps and you're putting synthetic mesh as an onlay, you might run into more trouble. If you're having the retrorectus position available, there's a lot more options to you. And then this whole question of are obese, diabetic, COPD and smokers, are they complex patients? And again, we don't really have that answer. But as Brent mentioned, this was a group of us that got together. I think it's important to point out this was industry sponsored, and I think this was really a first attempt at trying to get a general grading system so that we could speak the same language. Now, there's a lot of limitations of this, and this needs to be validated, and it needs to be looked at prospectively. But the general idea was to sort out, when you have a patient in your office, what are their risks for surgical site occurrence? And so this was the grading system, and it kind of broke it down into 4 grades. Kind of the simple grade 1 patients are the healthy folks that you see kind of low risk of complications, and in this the group recommended synthetic mesh. And then when you kind of go to the other extreme, the so-called grade 3 or grade 4s, there was a general recommendation for no permanent material. But let me just caution you, because this was one of my issues with this, and we have a paper that is in press right now, that previous wound infection, in my personal opinion, and I'll show you the data, probably it should not be in a grade 3, actually. I don't believe that necessarily predicts higher wound issues or mesh infections, particularly if you're using some of the meshes that Yuri and Brent spoke about, the lighter weight macroporous meshes in the retrorectus position. We've had excellent results in these cases with really no increased wound morbidity. But I think that it is fair to say, at least in my practice, when there's violation of the GI tract or infected mesh, it's reasonable to use one of the biologics or biosynthetic material. And then this grade 2 patients, we have some other data coming out with this. There was a clinical trial that was addressing this, but it was stopped. And I think that this is even a harder group, and I think it makes it even more complex when you have laparoscopy as one of your options as well. So again, in my opinion, no clear evidence to suggest the routine use of biologic mesh in this patient, and I think a lighter weight macroporous mesh in the retrorectus position, in my opinion, is perfectly acceptable. So Brent showed you the different materials. There's different sources. They can come from human tissue. They can come from animal tissue. You have the absorbable synthetic meshes, which I think is a new, exciting option in biologic mesh or contaminated repairs. BioA, which Brent showed you, there's Tiger mesh, which is a woven, longer-term absorbable mesh, and then obviously your Vicryl and Dexon meshes. And so, as Brent mentioned, a lot of stuff can happen with processing. I think that there's clear evidence that this affects mesh performance in a good way or a bad way, impossible to say without comparative trials. I think cross-linking, again, like anything we do, has both pros and cons. I think it tends to make the mesh a little bit more synthetic. And again, just to point out, I'm going to ask this question, and Yuri and Brent, you can't answer, but I'd like somebody from the audience, as we go through my talk here, I'm going to ask you the question of what is terminally cross-linked porcine dermis? I'm going to go back to that once somebody answers that question on the thing. First one to get it gets a free pass to SAGES. Brent's going to go ahead and support you on that. I'm just going to keep moving, and we'll go back when I get that answer to the question. What is the data? Well, actually tonight is our journal club. Brent Matthews is typing, nope, not acceptable. I'm going to try and answer this question, or try and look at this study as looking at it as journal club. And this was a recent paper published. It's the most recent, study that was published about biologic mesh a few months ago. And I just want to point out kind of the shortcomings of this and how we really don't have a clear guide, so we're all talking about the same patient. And if you just look at the title of this, they looked at so-called high-risk incisional hernias. Again, no definition of that. And they also included incisional and traumatic hernias, post-traumatic, which I think are 2 different groups of folks. They used a non-cross-linked porcine dermis Zen matrix, 57 patients. But when you look at how they graded them, they were all grade 1 and grade 2 hernias with no contamination. And again, fairly respectable recurrence rates. If you use it as a bridge, much, much higher. But again, what did they report? There was no wound morbidity in 57 so-called high-risk incisional hernias. And in my opinion, that's grounds for synthetic mesh, which I certainly think is appropriate. So when we look at the data, there's a clear publication bias to publishing only clean cases. And so if we look at this, this is a summary of kind of human data that's published, and it says challenging, but it really means contaminated ventral hernia repair. And so as you can see, some of the meshes, for instance, Permacol, a cross-linked mesh, 85% of the cases are in clean. Then Matrix, again, I showed you one of them, 85% are clean. And some of the other materials, again, have no data published whatsoever in contaminated fields. And that really made me open bar in the mini bar. That made me go back and really ask the question. In fact, importantly, this was funded by SAGES. We really wanted to look at how does infection and contamination affect the performance of these. And we looked at this in an animal model. This was published a few months ago in Surgical Endoscopy. And just, I'm going to kind of skip through this for the sake of time. But basically what we did is we looked at these 4 meshes, Permacol, Stratus, then Matrix, and Biodesign, and our positive control was Polytetrafluoroethylene. And in Cleveland, we kill a lot of rats and make a lot of hernias, and my residents in the lab really wanted me to kind of show off. This is how good our lab residents are at fixing rat hernias, and that's a nice functional abdominal wall. But what we basically did is we took a fluorescent labeled Staph aureus and contaminated these different materials in both a clean contaminated, and a dirty infected wound and a clean control. And then harvested them, looked at it histologically. We looked at, this is a little picture of the quantitative cultures with the fluorescent labeled, and then looked at biomechanics as well. And this is probably the key slide that I'm just going to focus on for the sake of time tonight, which is, this is looking at how well these materials cleared the bacteria. So on the y-axis, if you had 100% clearance, we found no bacteria. And then there's the 3 groups, the clean contaminated, the contaminated, and then the grossly infected or fecal peritonitis. And again, what you see is that in clean contaminated, they all do pretty well, and they're all fairly equivalent. But as the level of contamination goes up, these things start to differentiate themselves. And so again, one mesh might not be appropriate for all different fields. And again, fairly high levels of bacterial growth. Interestingly, the cross-linked material had the same growth as our synthetic control. And when we look at strength, again, the majority of them, with the exception, interestingly, as Yuri mentioned, Polytetrafluoroethylene, even in the face of contamination, will still grow into the abdominal wall, which can be problematic, particularly when having to get it out, still maintains its integrity. And this is the one slide I think that's important to realize, is that in these grossly contaminated fecal peritonitis wounds, I think it's important to realize the limitations of these. And although some of them can clear the bacteria, they start to break within the material themselves. So when you have fecal peritonitis, I think it's key that you actually clean out the wound, let them be in the ICU for a couple days, and don't use these expensive materials in these grossly contaminated wounds to try and get some bioburden reduction techniques. So, again, these things are very expensive. We all know that, and we certainly need data. But I think the key to this is that even the best biologic mesh is only going to be able to do so much. And no mesh is going to be able to work if it's not placed with good technique. And I think it's probably fair to say that almost all the meshes will work pretty well with appropriate technique. And so I think some of the keys, get the fascia closed. I'm an underlay guy. I don't think it probably matters what sutures you use to close or put the mesh in. But I do think one little technical point, if you're using a biologic mesh, realize that although we call these mesh, in fact, these are flat sheets of collagen, and they're not very permeable to fluid. And I do think it's important to leave the drains in and leave the drains in until they're dry. And so component separation, it's a very popular approach. I think one of the keys to this is you don't always need a big open endoscopic or any component separation, particularly when you have the reefs open. And Brent showed this, but I just want to show a quick video of this and really kind of get into this in detail, because I think probably, and I think all 3 of us would agree, that if there's any technique that we think is probably the most important thing to learn for everyday hernia surgery and even complicated things is a Reeve-Stopa approach. And I think for some reason the U.S., I think that this has not caught on, but I think that once you learn it, it's a great approach. So a couple quick things. When I do a SOAP, I get in the belly and then get back out. I'm going to show you a video, so I'm going to skip through it. But if you see that gold line there, that's the intercostal nerves that penetrated the linea semilinaris. And it's important to preserve those nerves. When you take the posterior sheath down, somebody asked about the blood supply to the rectus muscle. I'll show you in the video. You can easily save that. You close it back up. You get nice wide overlap. This is a revered needle that you see in the video. And this is just a typical case that I see. This is a gentleman that lives in St. Louis, and I think it's probably fair to say that this is a gentleman who took Dr. Matthews through his learning curve. I think this might be the year that Brent finished and started out in practice, and at that point he wasn't doing lap colon, so he did an open sigmoid colectomy. Then he got a hernia, and one thing that Brent's learned is that if one mesh doesn't work, try another mesh, try a bigger mesh, keep going, and eventually he put a big 27 by 22 Kugel composites. The wound broke down. Finally, he actually went to see the Rock and Roll Hall of Fame and saw one of our billboards with me and Yuri on it, and made it into our, I see Brett's tapping, into our office. And this is him with the big hernia and a exposed piece of mesh. And so, let me just, yep, good. So that's the hernia. I think one key thing is we've taken out all the mesh that was placed before. Let's see. I'm kind of pausing here. Yep, there we go. And then we're going to get in this posterior sheath. And I think this is probably the most important part of the operation. What you want to do is get right at the linea alba or about a centimeter off. And again, this guy's had 5 operations. And what you can see is, unless somebody else has been in this plane, you can always get back in this plane. And really all that's there is the inferior epigastric. There's a little suture right there, but this really is a nice avascular plane. I always kind of describe it as, are you guys unable to see the videos? Let's see, Steve, are they able to see those videos, or if not, I should just kind of jump through? Okay, so it looks like some folks are getting it, so I'm going to go ahead and, okay, good. So we'll keep it going. So anyhow, once you get into that plane, we're able to slide down. So there's your rectus muscle. Those are the intercostal nerves that are perforating at the linea semilinaris, and that's your marker. And you can see, especially when we talk about biologic mesh, this is the place, I think, and synthetic mesh, and why I think a lot of times you can put synthetic mesh in these fields is that you get such a good blood supply. There's Cooper's ligament, by the way. We've taken the bladder down. That this is a very rich supply of cells and whatnot to get into your mesh. And here you go. There's the right rectus muscle, left rectus muscle. And a lot of folks have a difficult time with how do you connect the dots up high. And so basically what you're going to do is you're going to drop the posterior rectus sheath off the linea alba. And then here comes the xiphoid process. And again, once we get underneath there, we get in the fatty triangle. And then we're going to be able to close this space back up and completely exclude the mesh from the bowel. And I think this is, no matter what prosthetic you choose, whether it's a synthetic or a biologic, I think that probably one of the most important things is how you place that mesh. And the most common mistake that I see folks make is that they place the mesh with the fascia opened, nice and tight. And then they close the fascia on top of it, and it wrinkles and it buckles. I think that's where you get seromas, that's where you get infections. So what I think the key here is that you use the mesh to set the tension on the abdominal wall. And I cannot stress this enough. So as you'll see, what we do is we put the suture through the mesh, and then we're going to retrieve each one of the tails with this revered needle. And then this is Prolene suture. Again, you could probably use Maxon. I think that's fine, or PDS suture. But you'll see when I put the next suture in, I'm going to pull the midline and set the tension where that suture should be. So the suture goes through, and I'm going to put my finger where that knot wants to be with a coker on the midline, set it to the middle. And what you'll see happens is now when we pull these sutures up, the mesh is tight. And so when I close the fascia on top of this, and you'll see how much smaller the defect is, and here all I've done is put the figure of 8 sutures in, and the fascia is already back together. And I think that whether a biologic mesh adds anything to these repairs, I'm not sure we know that, but I certainly think you have to use it in the right way to have a chance. And again, this is this gentleman here in follow-up, and unfortunately we don't have a great quality of life measure, but again, you'll see that even in St. Louis, even if there's a lot of giant cells in this one, I think Yuri would give me a break and say that it actually worked. And so, let's see, we got a couple more minutes. So let me just, I'm going to try and answer the question of what's the best compartment for biologic, and that kind of went through quickly. But remember, you could do an onlay, intraperitoneal, or a sublay kind of extraperitoneal retromuscular. And when you think about blood supply, at least to me, that retromuscular space makes the most sense. And so this is that study that Brent spoke about. This was, again, industry sponsored by LifeCell. It's a prospective study of infected and contaminated repairs using their product. And this was 12 centers, 80 patients, and again, multiple different outcome variables. These were kind of the worst of the worst. I'm going to cut to the stuff that I really want to show you. But importantly, there were no clean cases. So these were either clean contaminated or contaminated hernias. You had to get the muscles closed if you could, but you could have placed the mesh retrorectus or intraperitoneal. These were fairly big defects. These were long, complex cases. And as it turned out, a third of them were placed retrorectus and 2/3 were placed intraperitoneal based on surgeon discretion. And again, some fairly honest data. This is not outpatient. This is not outpatient surgery. Again, 12 days in the hospital, a week in the ICU. And I think this is an important study because there is some controversy now of whether synthetic mesh can be used in contaminated fields. And I think that should be studied. But I'll just point out, in this study in fixing infected and contaminated fields, 2/3 of the patient had some surgical site occurrence. So it's a fairly common event, and 1/3 of them were infections. And this is the data that Brent showed you. Again, I don't think that any of these things work well as a bridge, but I'm going to focus on this kind of when you reinforced it and you had a fascial closure. I'm going to look at these 52 patients where we got the fascia closed and they did a component separation, and the surgeon had the choice of intraperitoneal or retrorectus. And just to show you the effect of retrorectus, so on the left is retrorectus, the right is intraperitoneal, similar based on demographics. Importantly though, the retrorectus group actually had 100 square centimeter bigger defects, and that was statistically significant. So kind of a sign of a little bit more difficult hernias. And I'll just show you when you put these biologic meshes in, the recurrence rate was 3 times higher if you put it intraperitoneal than if you put it in the retrorectus position. The p-value was 0.14. It's underpowered. It's a subgroup analysis, but it certainly is a fair question of whether that might actually make a difference. And so with that, I'll kind of wrap up. Obviously, it's my bias that retrorectus is the superior place. I think it's all 3 of our biases who do this for both synthetic or biologic mesh. It's really the ideal plane. But I think that, these biologic meshes realize that they're different. We're just starting to learn about these things. You should have a lot more questions than you have answers. I think that using them as a bridge is almost a guaranteed hernia, but that sometimes is okay. But I think just consider this retrorectus position because I think that certainly that might be the ideal spot for these materials. So with that, I'll stop and hopefully have a couple minutes for discussion. It looks like I stirred up a good discussion up there.
You ready?
I'm ready.
Okay, we'll bring you live now.
Is Rosen wearing his pajamas at home?
Just got out of the pool.
There's several questions here about risk modifications. How strict are you two with smoking cessation and weight loss, and you know, what are your kind of criteria, especially for weight loss in patients who have these complex abdominal wall hernias?
Well, I think I'm going to go first. I think I was just typing the same thing. Meaningful weight loss is often difficult to achieve in those patients. We obviously require them, and there's a little lag of how soon we can schedule them. So oftentimes we always encourage that, and oftentimes patients fail to achieve any meaningful weight loss. Bariatric surgery is complicated because often they're too symptomatic, or there's a defect is in midline or upper midline, and it's hard to perform any bariatric surgery in that setting, and we don't like to combine them. We still don't know whether it's a good idea to combine or not, and sometimes patients do agree to undergo a lap band or a sleeve, but I think at this point it's more wishful thinking in terms of weight loss. I think we do have to adjust our expectations, and when we talk about the results and the expectations of success, you do have to preface it that the recurrence rates are likely higher, especially in the setting of biologic meshes, and patients need to be aware that unless they begin to participate in the care, that nothing is going to work as well. Mike, you can talk about smoking. I know you like that topic.
I mean, I think that, you know, I like to tell patients there's no way you can beat physics, no matter how good of a surgeon you are. The truth is, weight loss is not just a problem in hernia surgery, it's a problem in this country. Obesity, and I think none of us have the answer. It definitely increases recurrence rate. It definitely makes the operations harder. And I think that as your wait list for surgery grows, your impetus to make folks lose weight goes up as well. So I usually set a goal for people. I try for the Atkins diet. I'm not always successful, but I guarantee you that your recurrence rate is going to be directly related to whether these patients lose weight, and these are temporary fixes. Smoking cessation, though, is not negotiable for any complicated hernia, certainly fistula takedown. The lat ventral, sometimes I'll do it, but smoking cessation, folks need to understand that smoking prevents wound healing, and that is all we're really going for with hernia repair. So if you cannot get your patients to quit smoking, for me, I check their serum cotinine level at their PATs, and it's a non-negotiable. I think it's, in my opinion, complicated abdominal wall reconstruction. It is almost malpractice to do in the setting of a patient who is smoking, unless it becomes an emergency situation, in my opinion.
I just want to point out that St. Louis Cardinals are losing 5-0, in case Brent cares.
That's okay. There's plenty left. They usually do it in the end. What, with all these different meshes available, how do you navigate this with your materials management administrative people at your hospitals? Is it a real issue with you trying to get a mesh that's for a certain indication for use in your institution?
Well, so at our hospital, this is how we do it. We have one cart that holds the mesh, and if you want to bring a new mesh, another mesh has to go. And I think that's important because as these boxes get bigger and harder to fit on, you have to make difficult choices. I would encourage, and I know most is for the residents, but I would encourage that what surgical departments do is actually get all the surgeons in a room together and actually talk about what mesh they want to use and try and agree upon one or two, and then go and negotiate for the best price. The worst thing you can do from a cost perspective is everybody gets to use what they want with no real difference other than 62 giant cells on one and 43 on the other, and no real clinical data that we've heard tonight to suggest an advantage over any one.
It's a real issue at our institution, and we're seeing it more in our referring physicians who refer complex abdominal wall hernias in, that even they're getting more pushback about having a large inventory and not getting discounted contracts and the cost of it, just like, you know, every other surgeon and whatever their specialty is. Well, it's 8 o'clock, so I think we're going to go ahead and wrap things up. I certainly want to thank Steve Lamb again, who coordinates this from Case Western University and University Hospital Center, and of course SAGES support to do this. There is another webinar on November 15th on surgery in the obese patient. They're going to go through tips and tricks of operating both general surgical operations primarily in these patients. If you have any other questions after the seminar, certainly our emails are available, and you can contact us, or you can go back through this podcast on the SAGES website.
Oh, hey, Brent, real quick. It's leather. I never answered that question.
Oh, yeah, that is true. It is leather. I want to congratulate Mike on having one of his best hernia surgeons in the world trophies in his bookcase right behind him.
Here.
All right, well, thanks, everybody.
All right, thank you. Thank you, Brent.
Bye-bye. All right.